I'm James Hughes, bioethicist and resident techno-progressive.
And I'm Nira Zakovich, philosopher and resident Luddite.
And you're listening to Prosthetic Gods, an optimist and a grump on tech, a podcast where we explore the social, ethical, and political impacts of emerging technologies. Today's topic, we're going to address the topic of bad knowledge, whether it's always good to know about your own health. And I think it has ramifications for other kinds of knowledge, whether it's good to know other things, like if the world's about to end, those kinds of questions. But we'll start with the bad knowledge questions.
Yes, it is.
It is.
Problem solved.
Yeah. Well, I don't know. I think some of the same arguments for why it's not always good to know your own medical conditions might be applicable to other situations. But the kind of thing that we're thinking of here, when I got married back in 1988, Illinois had passed a law that everyone who wanted to get married had to go do an HIV test. And of course, we've had STD testing laws for marriage in many states for a long time. And this was just another one. But since I was working in medical ethics at the time, I was very sensitized to the question of the fact that in 1988, there were no therapies for HIV or no cures, and there's still no real cure, although we're getting closer to a cure. And so the question was, is it ethical to require people to have knowledge of something where knowing it doesn't change what we tell them to do, right? If I wanted to get married and already was sexually active with my wife, then we both had the same HIV risk at that point. And the knowledge of having HIV wouldn't change our behavior in any way. And for people who didn't have, who weren't getting married, you would want them to practice safe sex anyway. So if you got a negative diagnosis of HIV, there's the potential risk that people would act more risky than they should, and you don't want them to do that. So I think it was a tangible question at the time, and as a consequence, we went and got married in Wisconsin because they did not require that. It was more of a principle thing for me. It wasn't that I was personally scared. I eventually did get HIV testing and was negative, thankfully. But it has been a question over many, many different kinds of diseases about whether we should promote early knowledge of disease risks, under what conditions, for which kinds of patients, and so forth. And you saw an interesting article about this woman in the New York Times. You want to tell us about what she did?
Yeah, the New York Times Magazine a little while ago ran a very interesting story about a woman who had remarkable olfactory or smell capacity that turned out to predict with great precision whether people had Parkinson's or not. And she was put in touch with the Parkinson diagnostic community and tested pretty thoroughly. And it turned out that she actually can predict based on a person's smell many years ago, the existence of the disease many years in advance, probably of the same universe as olfactory tests for cancer that are being developed in dogs and so on and so forth. But this was not a dog. This was a person who had this amazing capacity. And, the journalist who wrote the story came to see her and was sort of thinking to themselves, it was an awkward kind of moment there. Do I want the person to smell me? Do I want the person to tell me if she smelled the intimations of Parkinson's on me? What would it even mean to know when you have no clinical symptoms that you are likely to get the disease, 15, 20 years down the road? So it raises the same kind of questions. As you say, in different diseases, there's a different amount of things that you can do in advance about them. So I would assume more in Parkinson's than, for example, in ALS, right? But
ALS is a classic example in this case because there's still no cure for ALS. There's evidence that you might be able to slow down its onset and progression with diet and exercise. And so that's one of the factors here is early diagnosis in many cases would allow you to attempt what there's some evidence for prevention. And even if there isn't evidence for prevention, it might allow health systems to research prevention by having you do things, right? So,
Right. Yeah.
yeah.
I mean, I guess my question is there seems to be cases where there's a mismatch in the last couple of years. This has come up, pretty prominently with Alzheimer's. There's blood tests and biomarkers for the existence of amyloid in the brain, which more often than not, I guess that's somewhat controversial, but develops into Alzheimer's. Um, there's stuff that you can do behaviorally to slow it down. There's also some medications for removing amyloid from the brain. Again, the effects of these, I guess, are still being the effects and the success of them are moderate and they're being studied, but I guess they can slow down the disease by 25%, which is pretty significant. But you have this universe where the diagnostics are much more powerful than the therapeutics, right? Where the capacity to diagnose is much more accurate than the therapeutics. And I guess my question, and it's genuinely a question in this case, is isn't there something problematic about being able to tell people with great accuracy that they have something devastating and not being able to give them a bunch of tools?
One of the ways that this question comes up is not so much in the United States or in the English-speaking West, where truth-telling to patients and patients' right to know is considered sacrosanct. But in countries like Japan, there used to be a common practice that if you diagnosed a senior citizen with an incurable cancer, for instance, that you would not tell them, and you would tell their next of kin, their caretakers, and you would tell the patient something like, "You've got, bad stomach," and the rationale for that was that why burden someone who's about to die with the knowledge that they're about to die.
Right.
And I think there's a question there about how compos mentis the patient is, the person is. If they're significantly demented, then maybe there's a rationale there for not burdening them with knowledge that they may not understand or be able to do anything with. But I think one of the first questions is, can you live an authentic life? If you're compos mentis, can you live an authentic life in ignorance of something so fundamental, right? It's like saying people can have happy marriages if they determinedly remained ignorant of their partner's indiscretions or whatever, right? So where do you have a position on that about the kind of authenticity of living happily and refusing to know that you're about to die?
Yeah. I mean, so this is kind of part of the truth shall set you free sort of ethos that we're
Exactly.
obsessed with, right? I mean, look, a preliminary question that's related to the informed consent point that you bring up and how seriously we take that is if the possibility of knowledge is presented to you, do you really have a authentic, genuine choice not to know? So, if you're standing next to that woman in the New York Times Magazine article, how strong is the temptation to, okay, just tell me? So, like, for example, what kind of decisions can we really expect people to make and not to make? Can you really expect someone to sort of reject the knowledge once they're told you can just open this website and you'll see what your risks are? So that's one question for me. The other, more directly to your point about can you live an authentic life in ignorance? I mean, if you've made the decision, which, as I just said, is probably hard to be in that ignorance for sort of philosophically informed reasons, then yes. I mean, you can know that certain kind of diagnoses are fundamentally going to change your life. That certain kind of information is fundamentally going to change your life, that they're going to have some sort of probably deterministic impact on how you're going to live. I mean, I don't know, ask yourself, if you were in the company of that lady in the Times article, would you want to know if you're feeling completely healthy. I don't know if I would withstand the temptation, but I wouldn't want to know because I feel from then on, if she said yes, even if I didn't feel anything, I would become a sort of in the mindset of a Parkinson's patient, and that's would be what I would be doing.
It's not a hypothetical for me because I adopted or I bought into 23andMe, I think a decade ago, whenever they first started.
Mhm.
And shortly after they started to provide Alzheimer's and other predisposition tests, but they put them behind a barrier. You had to click to say, I know the risks of knowing, and I would like to know this. Everything else, like your predisposition for left-handedness or whatever, that was just something they were going to tell you. But they put the serious disease risks behind this barrier so that you had to make a conscious decision about it. And
Yeah.
of course, I did want to know. But the problem with those kind of tests is that they're often wrong. Like for instance, the test said that I had no risk for celiac disease, and I have celiac disease. So
Yeah.
the and so knowing that you have slightly elevated risk for Alzheimer's in that context may be bad knowledge because the knowledge is not good enough to actually be a burden for you.
Yeah. By the way, was it extra money to
No,
get?
it
Yeah.
was part of the same set of tests.
Yeah. Because you could also see in the diagnostic business world that knowledge that is, sort of profoundly tempting would be especially valuable financially. People could,
Well, there's an important question there about the interests of health systems and insurance companies in general. Insurance companies would like to know as much about you as possible so they could theoretically tailor your premiums to precisely your health risk. And of course, that was addressed in the 90s by the Genetic Information Non-Discrimination Act, which said that that kind of information, genetic information, should not be used to discriminate against people for insurance purposes. And
yeah.
then we had the Obamacare restrictions on pre-existing conditions. So we've attempted to address some of these kinds of things, but just know, when you go to your doctor, one of the first things they should be talking to you about is your family history. So just aside from any other testing, once you tell them that both of your parents died of cancer, you have a heightened cancer risk, and so you've already acknowledged that you have one of those risks. So and that's important for the health system and for your provider to know. We don't want you to be discriminated against, but it's important for everybody to know.
Yeah. I guess there's still a difference between sort of saying both of my parents have a certain kind of history and then seeing a piece of paper with an analysis of your own genetic makeup. The plausible deniability goes down pretty rapidly. And I guess part of what prompted our conversation on this seems to me that plausible deniability is a condition for a good life sometimes.
Yeah.
It's interesting, the cultural difference that you brought up earlier with Japan. Seems like that there's just more than one version of what it means to have respect for persons, right? In our case, it's informed consent no matter what, as it were. And it seems, I don't know much about the Japanese case, but from what you said, it seems like the respect for persons there is sort of mercifully maintaining some of that deniability,
that
or
that practice has been on the decline in Japan, from what I know.
it's been on the decline. Yeah.
Yeah,
So they're moving closer to the informed consent model.
yeah.
Yeah.
So one of the ways that this impacts me is I'm always plugged into the medical news, and
Uh-huh.
when I know someone with a serious medical condition, I immediately start seeing research, usually on rodents, about that condition and the cures that are possible. And one of the ethical decisions I often face is, should I share? Like I had a friend with pancreatic cancer, and every day I was seeing pancreatic cancer therapeutic research that was probably 10 to 15 years away from any kind of application, if anything, and they were going to be
Right.
dead before that. And so
Right.
I made the decision not to be sharing that stuff with them. So I think there's implications not only for the patient but also for what we share with other people.
Right. Right. And in the case that you bring up, there's a big difference if the person already has the diagnosis and there's some new information that is out there, and actually getting the diagnosis in the first place. I mean, also, So you're absolutely right. There's a set of implications on other people. My decision to, for example, be smelled by that person who can detect Parkinson in advance is not a decision just for me. It's also a decision, right, for my immediate and family and friends, right? And
That's a
again,
big issue, for instance, with ALS, because it's such a terrible disease. And once you have an ALS diagnosis, your family knows that they have a 50% chance or whatever of being ALS as well. So you're making a decision. Once you get diagnosed, you're making a decision for your family as well.
right. So on the one hand, you're making a decision for them to either seek early diagnosis or engage in some behavioral changes. But you're also in that moment, if you're going to get a diagnosis far in advance um, of the appearance of clinical symptoms, which increasingly is going to be possible, right? You're also making a huge lifestyle change decision for your family. You are literally pulling in a sort of cloud of anxiety over the family where there could have been another 10, 15 good years, right? Is that an issue? I mean, for me, there's a sort of slippery slope kind of dynamic where this moves to, I know you don't like the movie, but it moves to a sort of Gattaca scenario where, the kid is pricked in the heel at the beginning of the movie, and the endless printout of the likelihoods that he'll get everything from heart disease to cancer and asthma, et cetera, start running up. And
Well,
that changes how you treat
you're
them.
pushing my buttons by mentioning Gattaca, because I
I
hate
know,
that
I know.
movie.
I mean, I waited 10 minutes before starting to push your buttons. I feel very virtuous.
Well, let me just run through quickly my objections to Gattaca. In the first place, this was a future projected in which universal genetic I think preconceptive, or at least prenatal diagnosis of conditions and genetic modification of embryos appears to be ubiquitous, that almost everyone's doing it. And the
Yeah,
protagonists' parents are hippies who decide, oh no, let's just roll the genetic dice, and they end up with snake eyes or whatever, and the kid has a lot of predispositions to early death from a heart
right,
condition. Then he decides to defraud NASA by pretending to be somebody else with somebody else's medical, blood
right.
and skin and everything, so that he can have a chance to die in space as an astronaut, as he always intended. And the film is passed off as an argument against universal genetic knowledge and universal genetic therapies for congenital conditions, when in fact, to me, it reads as an argument against hippie parents irresponsibly making these decisions for their kids, and against people being able to defraud the government, to be an astronaut of all things.
Yeah.
So yeah, I just think it's a terrible argument. But it's also, I just want to also point
It
out, and
could
this
be
is,
both, by the way.
yeah, but it's also a future that doesn't make any sense because the technology has progressed so far, but apparently there's no cure for this guy's condition, right? There's no gene therapy, drugs,
Right.
and that doesn't make any sense. And I think that's relevant to this argument as well. It's like
Yeah.
our assessment of how quickly therapies will come online affect all kinds of medical decisions. If you're a mom trying to make a decision about whether to continue a pregnancy where you've been told that there's a congenital abnormality, one of the things I think you should think about is how fixable this problem for your kid is going to be in the future if we accept the term fix. I mean, what kind of therapeutic options are there going to be for this condition in the future? And if
Yeah.
you think there's going to be a lot, then that changes the nature of your decision. So similarly, even if there's no cure now, knowing that there's a dozen different potential therapeutic avenues being explored, maybe you should know now, so that as soon as something comes available, you can take advantage of it.
Yeah, although all of those factors are then outside of your control, how quickly those therapies come online and how quickly they're actually available to consumers. So I mean, I guess coming back to reality from Gattaca, we do live in a market-driven society. there's a lot of money to be made from getting for example, Alzheimer blood tests out there, right? And um, selling them. But there's a real lopsidedness where what's actually going to end up happening is that the diagnostics are probably going to come online very quickly and become part of primary care. And you're going to maybe get one if it's plausible in your annual checkup. But then what you won't have and then you'll be told, well, you're getting this, your chances of developing it in the next coming years are X. You should engage in a bunch of lifestyle changes, and you should probably also see a therapist. And then there won't necessarily at all be the structure for you to start going to physiotherapy or start going to do exercises or, start seeing a counselor. So one thing I worry about is that not only do the diagnostics outrun the treatment possibilities, but the diagnostics also outrun how serious and caring the broader healthcare system is. Does that make sense?
Yeah, I mean, I think the one of the social questions is should a system encourage aggressive testing of early disease risks when there aren't therapeutic avenues and when the false positive rate is very high. So, for instance, with mammograms and prostate cancer, we've had this question for a long time that knowing that you have many men over, many senior men develop enlarged prostates and have enhanced prostate cancer risk. Prostate cancer takes 15 years to kill you, 20 years to kill you, if it ever kills you. And there are therapies for prostate cancer, but they're rarely used at the very earliest stages of detection. So should you be testing a bunch of men and falsely diagnosing them with prostate cancer or prostate cancer risk when you're just going to make them miserable and there's not really that much that you should be doing for them at that point? Should we be doing a lot of preventive mastectomies for lumps that have some cancer risk but are not yet cancer? Should we be doing screening where we turn up a lot of these kinds of cases? So those are issues that health systems have been grappling with for a long time, and advice about what kind of tests to do has been going back and forth.
Right. And they can also have sort of identity altering effects. So if someone gets very anxious about a prostate diagnosis and they get surgery, that often results in erectile dysfunction. And mastectomies have significant impacts on body image and self-image and so on and so forth. So, and these are harder risks to quantify and define, and yet they have a massive impact on everyday life. So, how does is this just part of every person's informed consent? Is this something to be taken seriously on a policy level of how much you sort of incentivize these kind of early diagnostics?
Right. So that you can separate the questions there. Do people have a right to know? I would say I'm pretty much on the saper out side of that. Dare to know. You should know everything you can possibly know. On the other hand, does society and your health system have a right to not provide tests that you want to use, right? So a lot of patients will go in saying, if you have a test for prostate cancer, breast cancer, I would like to see it. But the system then has to decide which patient should get it. And so in that situation, the system should say no to some patients if what willingness to know is ahead of what should be known.
Is this just a version of the healthcare rationing question? So we already do that regularly. You're not going to get an MRI most likely for something that's very, very likely not going to afflict you just because you have a sort of 1% anxiety that you have it, right? So,
but this also is relevant to over-the-counter medicine, right? So like you're going to get it. I think they're over-the-counter HIV tests. And one of the concerns about that is, should patients be finding out that they have HIV without medical support, medical counseling? But I would say if you should have a right to buy any medical test you want, and find out anything you want, but the health system doesn't have an obligation to provide it.
Right. Yeah. I mean, I guess the point I was trying to make earlier is that early diagnostics like this, especially in borderline cases where there's not a ton that you can do about them, especially even when the diagnostics are not clear. So Alzheimer is an interesting sort of borderline case. There's some stuff that you can do about it. The diagnostics are not 100% because there's still debate about, the absolute connection, I guess, between amyloid presence and Alzheimer's, and sometimes dementia diagnoses spontaneously somewhat improve. I guess rarely, but they do. Under those circumstances, it seems like early diagnostics make sense in a more compassionate context than we have. What's likely to happen, from my experience with the American healthcare system in the case of early diagnostics, is you get your early diagnosis and then you're kind of on your own in terms of counseling of what to do about it, in terms of helping to pay for the lifestyle changes that you could make, which were the reason why you got in the first place, and in terms of managing the anxiety and the family dynamics that it would definitely bring. So under those circumstances, it becomes a little bit barren to just talk about, informed consent.
Yeah, I don't think informed consent's the only thing on the table. And is it even informed consent to talk about early disease risk? I mean, the Buddhist mantra is sickness, aging, and death, the inevitability of sickness, aging, and death. So we already all should know and have at the top of our mind that these are inevitable things, or more or less. So yeah, is there an obligation to knowing a slightly increased risk of one thing versus another? I'm not sure that there is. And it is in the social context of the obligations of society and the goals of society. I would say one of the things I do think that should be on the table is your obligation as a research subject. And very few people ever talk about this, but many people who get inducted into phase 1 clinical trials, one of the motivations that they are willing to undergo what is probably not going to be a therapy, but is just a test for toxicity, is that they want to help other people with their condition. So I think if you think of yourself in that context, even if there's no therapy for Alzheimer's yet, maybe I could be one of the people who, through my course of action, demonstrates that Alzheimer's could be prevented or slowed down.
Yeah. So I was going to ask you this in the beginning, but I'm curious. So if you were in the room with that person who can smell Parkinson, I think I mean, our listeners should actually check out the article. I think she makes it a policy not to talk to people, but abstracting from that for a minute, would you ask, or would you just like put on a bunch of deodorant and make sure that she can't smell anything?
Parkinson's,
If you're fine, I guess. Like if you
yeah,
weren't feeling any early symptoms yourself.
I would take it as one piece of evidence. I mean, I don't think that it would disturb me terribly much. And I
No, but
do,
would
and
you
I
would you ask though?
would
So
I ask them to smell me? I don't know. I guess it would depend on their emotional burden. If she's already decided that she's not going to go around telling people, maybe
if
she
she
doesn't
if
want
if
to.
she leaves it up to you.
If she leaves it up to me, yeah, I think I would. I mean, I clicked through all those 23andMe tests just to see what they
Yeah,
said, and I
yeah,
wasn't terribly disturbed by what I found. So, but
yeah,
yeah, I'm the kind of person. I think there's a life planning question that serious disease risk informs what kind of choices you should make for your life. I'm 63, and my dad died at 60. And so it's very much on my mind. Should I be making life choices that assume another 5 years of life, another 10, 15, 20 years of life? Those are different choices. And I'm trying to use my medical knowledge to inform those choices.
yeah, yeah. I mean, there's life planning is one question. Life course is another. So, for example, in that specific case that we were just trying to imagine now, and part of why I'm insisting on it is I have a feeling that similar examples are going to actually keep coming up as biomarker technology advances. Is, you're right that this can help your life planning and taking care of your family, etc. But it could also completely alter the course of your life. You could sort of change the focus, maybe justifiably, maybe not, of what you want to do, what you're interested in. Um, this would not only change your life planning, I think it would also potentially, and quite likely, at least for some people, for me, it would, I think, change what you're actually going to do with your life.
But that you're saying that wouldn't be a good thing. If I decide I'm going to keep working for another 5 years on the assumption that I'm going to live forever, and I'm actually not.
I don't know if it's a good thing. It's just a different thing from life planning. You could, I guess you have to not only sapra oda, but also know yourself before you engage in these kind of decisions. Because if you're the kind of person who's going to sort of start obsessing about this, and if you're the kind of person who's going to be consumed by this, so I think it's much better not to know. It's interesting, by the way, we've been talking a lot about psychotherapy too. I mean, the question of bad knowledge isn't necessarily limited just to diagnostics. So the sort of untested premise in at least psychodynamic psychotherapy or Freudian inspired psychotherapy is that knowledge is always a good thing, and that sort of excavation of knowledge of the past and sort of airing out and giving words to is always superior to repression and denial.
I'm glad you went there because this is one of my complaints about psychotherapy is that
Yeah,
there's substantial research, for instance, on trauma victims, and the kind of usual psychological intervention is to go in and talk to patients about the
right.
trauma right after trauma. That turns out to be terrible for PTSD. It reinforces the traumatic memories that cause PTSD. And conversely, the mindfulness approach is to just let it go, to not focus on or relive any of these traumatic memories, but to note them and just let them go. Now,
Yeah.
there's also research that shows that even looking at your mind in that way can become obsessive compulsive for certain people and counterproductive. But for me, the evidence seems to suggest that psychotherapeutic approaches is just reinforcing all the negative crap in your head instead of just letting it go. But anyway, it's
Yeah.
a
Well,
slightly divergent.
yeah, I mean, I think it can be. And I think so. I don't think that one should axiomatically sort of assume that talking about it and airing it out and making a coherent narrative is out of trauma is always the only and the best solution. I think there's probably a tipping point after which it sort of reinforces, as you said, the trauma. Yeah, I mean, look, repression and denial, which are the sort of versions of not knowing, right? In this
Mhm.
context, are automatically assumed to be awful and wrong. I think there's a case to be made for them under some circumstances. There's a great, there's a classic book on by Jean Amery, the philosopher Holocaust survival, on the virtues or on the possibilities or a defense of resentment rather than sort of, working trauma through and forgiving and, or coming to terms with, et cetera, et cetera. And part of the general neighborhood of that argument is some things are, in that case, bad enough that you kind of actually, that the way you keep yourself alive is not working them through, but, either repressing them or lingering on them and insisting on them and holding on to them and staying resentful. So, there's definitely a bad knowledge question in psychotherapy too. And in psychotherapy too, I think sometimes there's a case for denial. I mean, I guess my psychotherapist acquaintances are not going to be happy for me saying that, but
Well, the Bush President's Council on Bioethics published a book back in 2002 that was a broad attack on transhuman therapy. I'm spacing on the name right now, but the
beyond therapy.
Beyond Therapy.
Yeah.
And one of the chapters in that book was about memory modification therapies.
Hmm.
And I think it was Leon Kass who made the point in the book that we wouldn't want people to forget the Holocaust if we had access to memory therapies that could suppress traumatic memories. I think the idea of people forgetting the Holocaust is hyperbolic, but in the context of war, people have made the argument that if soldiers took drugs that kept them from having traumatic memories from combat experience, would it be bad because people should remember how traumatic combat is? I think
Right.
that's also a hyperbolic argument because I don't think very many soldiers, just because they don't have PTSD, are going to be more willing to go back into combat, but maybe, who knows? But in the extreme, there is this question of should we be able to suppress memories in general for good
Yeah.
reasons?
Let me go back for a minute though to our main topic. It seems like maybe we should distinguish more clearly between two of the criteria for getting an early diagnosis. And one question is how much is there we can do about it that we talked about? And the other question is how early is the early diagnosis?
Right.
And
And
so
how
if,
certain?
right, and how certain, that's right. And so, almost like if we were making a decision grid, my sense would be if it's not super certain, so if there's a lot of false negative, there's not a ton we can do about it. And if it's very early, while I'm still not having symptoms, I just wouldn't get it personally.
Right.
Uh,
And
and
there's not
if
a clear therapeutic or preventive course of
Right.
action.
Right. And as you say, to some extent, there's probably always a therapeutic course of action. I mean, you should always be on the Mediterranean diet and see your friends and exercise.
Right.
But if there's nothing beyond that, if there's no clearly helpful supplement, blah blah blah, those seem to be the three factors. Is there anything you can do about it? How early is it, and how sure is this to be accurate? If there's not great answers to all three of those for myself, I would not be getting the blood test. What's your thought on that?
I think the individual choice should always be up to the individual. But then the social choice is the one that is a constraining factor there. That I think, yes, I agree. You personally, there are certain things I'm not interested in exploring yet because the knowledge would not be sufficiently strong to inform my life choices. But there are tests that, if I could pee into my toilet every morning and have it tell me whether it saw cancer markers, even if the risk was relatively small and the knowledge was relatively imperfect, I would still buy that toilet, right? And the people are working on things like that. So
Yeah.
but should the health system have an obligation to provide me that toilet? No. Or should my doctor accede to every request I have for testing? I don't think so. So it's not just your individual choice, it's also the social choice.
Yeah. I mean, yeah, I guess here is, slightly where we diverge too, because that sets in train a set of tendencies where then you also pee in the toilet to sort of figure out what your, lipid levels are, and you pee in the toilet to figure out what your VO2 max is, and how fit you are, and
I'm wearing well, I'm not wearing it right now, but I wear a Fitbit, just to tell me if I'm dead yet or not. So
yeah,
I'm all in
yeah.
for that kind of knowledge.
Yeah, I'm also wearing a Fitbit, but you'll laugh at me for this. I take it off every evening and I put it very far away from me, because I don't want to know how good I'm sleeping and how much oxygen I get at night. Because A, it's going to make me even more neurotic than I am, and B, I feel it makes you take yourself too seriously. It makes your head big. Like, you're not important enough to know exactly what level of oxygen you get when you're sleeping. You shouldn't be making yourself your own project in that kind of way. And I guess, as always in the sort of cure enhancements debates that we've been talking about, the technologies that are going to, in the end, generate these powerful early diagnostics are also going to give us early diagnostics about bullshit stuff. And we're probably going to take the bullshit stuff along with the important stuff and become shittier people as a result.
I don't know. I mean, I think if we told in a sense, we've already told everybody in the world they have a risk of dying earlier if they don't eat right and exercise. And it's
Yeah.
had marginal impacts, right? People know they should eat right and exercise and that it might contribute to earlier death, and they don't do anything about it. So I don't know that this is that. I think people adapt relatively quickly. There's also the kind of happiness adaptation thing going on here is like when people break their back and become paraplegic, they are sadder for 6 months to a year. And then they go back to being as happy as they were before. And
Hmm.
conversely, if they win the lottery. So I don't know that these early diagnoses are actually that traumatic. If it's a senior citizen who's demented and they've got 6 months left to live, yeah, why burden them with knowledge they may not be able to do anything with? But
Yeah, yeah. Let's shall we move to our
sure.
news roundup? We have some cool stuff to talk about there
I
today.
just want to underline you're against knowledge and I'm for knowledge. Is that where we came out?
I'm more against knowledge than you are. I think we're not as
Yeah.
far apart. Disappointingly, we're not as far apart on these. But I would mainly go down that road if the diagnostics were very accurate, if there was a good amount that we could do about it, and if I actually had reason to suspect I needed the diagnostics. Otherwise, I would happily be wallowing in denial. Yes.
Okay. Well, in terms of our lightning round, we picked out a couple things. We'll see how far we get. The first one is that Google has hired the Character.AI founders, who are spin-offs of Google to begin with. They left Google in 2022 to start Character.AI, which has become the dominant, I think it's the largest player in the field uh, of AI friends and potentially AI romantic partners. And they are valued, I guess, $1 billion. And now Google's reabsorbing them and has rehired them to help Google put character type software into what they're doing. So Google Gemini, if you have an Android phone, you can already enable Google Gemini as part of your Android voice, I believe. And I have a Google Hub in my kitchen, and I talk to it every morning, ask it to turn on various radio stations. But it's not very smart. You ask it something, and
Yeah.
it says, "I don't understand." But if we enable these chatbot AIs and give them personalities, I would have an actual conversation with this, I imagine, in very short order. And this is probably something that's going to be released in pretty soon.
Yeah. So why are they doing that? What do you think that this means in terms of their strategic direction? So it definitely seems like this is a move from search to something very different.
I think there's a couple things that everyone in this field of AI expects to soon happen. One is agentic software that you can tell to do stuff, and it will be smart enough to do it. There's a system that was released a couple weeks ago called Sakana.ai, which purports to do every step of scientific discovery, coming up with hypotheses, testing the hypotheses, setting up experiments, and evaluating the result. So we're not quite there yet. I mean, there's a bunch of steps involved with Sakana AI, but to have a system, to have Google Gemini on your phone and be able to tell it, I'm planning to go to Fiji next year. Keep an eye on plane prices. When a plane, when a fare reaches a certain point, buy it and then tell me that you've bought it and then reserve a hotel for that period of time. You'll be able to tell your phone to do that. You'll be able to tell your Gemini agent to do that. Now,
Hmm.
what will the interaction with that Gemini agent be like?
Yeah.
Will it be that you just click buttons, or will you actually have a conversation with something with a personality that knows you and says, well, you said you wanted a hotel. Do you want this kind of hotel or that kind of hotel? Based on what I know about you, you probably want this kind of hotel. Do you want that kind of system, a system that actually has a personality informed by all the knowledge that it has on you? And I think that's where we're headed with character AI.
Yeah, yeah. So it seems like there's a real sea change coming from Google's business model of search and ads that go with websites found. If you combine the desire for replacing search by AI, essentially, so giving you the best kind of summary of the query you searched with this hiring of people whose specialty is to make chatbots more interactive and more attractive and more fun to interact with, um, Are you seeing this as part of a direction for changing the business model of the internet, essentially to somehow monetizing irresistible conversations with chatbots?
Yes, I do think character AI has got a lot of experience now with how the upsides and downsides of allowing people to develop parasocial relationships with AI.
Hmm.
And Google wants to use that expertise and the software that they've developed. So I do think that that's a direction that we're headed. I think there's still an open question about how many of us want this kind of AI familiar in our life.
Yeah.
The other direction I think things could go is to not have that AI have a personality of its own, but for it to just be a seamless expression of your own personality. So without talking to you, it expresses your needs and wishes in the space. How exactly how that I think you still need to tell it something somehow about what you want, but it wouldn't necessarily be something that everyone would want to say, Joe, please do X.
Yeah. If I'm a Google executive and I'm taking a subway and I'm seeing how many people are already addicted to their phones by shitty technology like Snapchat and Instagram and TikTok, and then you say, huh, I have a nice captive audience here. Maybe we replace this by social chatbots on, every operating system of every phone. The possibilities there, for making money and for psychological harm, apropos the Jonathan Haidt kind of discussion, are pretty remarkable. So, in other words, if something as primitive, relatively speaking, as the social media platforms that we have can sort of glue people to their phone, imagine how much a character AI world can do that.
Well, we were going back and forth about the virtues of choice in our conversation yesterday, and I think for me the only way is forward, not back. In other words, these technologies will provide us a way to potentially control all the negative aspects of interacting in the digital world. It will allow us to potentially better identify misinformation, to better manage our time and our preferences. If our preferences still end up to be spending 3 hours a day scrolling through TikTok, I don't know what the AI is going to be able to do about that. But to the extent that many of us say, I would like to do less X in the world, I think that one of the things that will be on tap is to tell your AI, help me do less X. And
Yeah.
that's probably going to be more effective than just moralizing against people doing X.
Well, then I'll be out of it. Then what will I do?
Well, that's the problem. I think we're all, we're all going to be out of business. This relates to the other topic that we talked a lot about on automating therapy, which is the degree to which cell phone addiction or social media addiction is contributing to youth mental unhappiness and mental unhappiness in general. And a lot of schools, as you pointed out to me, are now adopting the cell phone ban in schools. I told you all when we were having this debate that I'm fine with that. I think most liberals are fine with the notion of banning cell phones in schools. There may be certain circumstances in which they need to be used. It seems like the lowest hanging fruit of Jonathan Haidt's agenda, and something that is so popular that every school can do it without bending anybody's elbow.
Yeah, it's interesting. Although some parents, having acquired the habit of constantly being in touch with their kids, and some kids having acquired the same habit, are still unhappy about not being able to micromanage every breath that they take. So there's that. I do think that you're probably right that it's on the margin. It's also a bit of a case of cheap virtue, in the sense of parents feeling and schools feeling, oh, we did something very important for the ability of our kids to concentrate by locking up the phone. The other part of Haidt's argument was, of course, you have to see people in the real world and hang out with them. You have to, play a game, with your family. You have to sort of do the things that require more actual time investment and presence. We'll see if that's harder to do that has more costs than putting the phones in a locker. We'll see if that part happens. But I think actually, we both see students, and I have a teenage daughter at home still. It's a huge attention suck, and I think there's only good things in making it go away for the day at school. So I am all for that. I suspect that it's going to be the only part of Haidt's agenda, of Jonathan Haidt's agenda or Haidt's agenda that's going to be implemented.
Yeah. When I went to college, I was so excited to be away from home that I didn't communicate with my mother very often. And she offered to pay me $10 a letter if I would just write to her. So the change when we were parents, and as you say, when our kids were in college, we were in constant electronic communication with them. We had a family group chat. I think it's better. I think it's better to be in constant communication with your kids. We both know, and because we're in higher ed, that parents harassing you about the grade that you just gave their kid is problematic, and that kind of helicopter parenting can be infantilizing for certain kinds of students. But I think the idea that parents and kids and families are in closer electronic communication, to me, is a good thing. They don't have to be between the 6 hours that they're in school. But
yeah, I mean, like all technologies, it has the problem of boundary drawing. Constant communication and signaling to your kid that you care and that you're involved is a wonderful thing made possible by smartphones. And then the overdoing it is also made possible by smartphones. By the way, I looked into the new dumb phones. I'm forgetting the name, but there's a cool, slick new looking new dumb phone with a sort of black and white screen, and fewer features. It has podcasts, it has the camera, it has the texting, but it kind of kills the other features. And it's literally $800. So you pay money. It's a brilliant business model, paying money for what a device can't do. Yeah.
Pay for less.
Yeah.
Well, that's a good example of for people who really feel like controlling. I mean, this is a key factor about self-control in general, is that controlling your environment is one of the most important things you can do to control your behavior. Not having alcohol in your house if you don't want to be drinking alcohol, et cetera, et cetera. So I think to the extent that there's a market for people buying technology which restricts their ability to do things that they know are tempting. I've never bought a game console because I don't want to have it in my house because I know it's got that temptation to it. So that I support that kind of self-control. But personally, I'm not willing to give up on I want to be there when the singularity happens. I want the news tone in my ear to tell me that I've been uplifted. So
I wish we stopped right after you said I support that kind of self-control, All right, sir.
Okay, well, it's always a pleasure.
Yeah, we'll try to fight more next time.
Okay.